Well, welcome everyone. My name is Bob Linscheid, and I have the pleasure of serving as Vice President of Opportunity for the East Bay Leadership Council, which incorporates our economic development, healthcare, and talent and education task forces into one uniquely positioned group to handle a number of issues that are being faced by business today. We're grateful for your opportunity to be here with us, and that's basically it for my role. I'm going to turn it over to our able-bodied staff, Kristen Conley and Lindy Johnson. It's going to take me a while to change the last name, Lindy. Lavender just seemed to flow a lot faster, so bear with me as I trial through that. But take it away, Lindy.
Not a problem. It's taken me a moment to get used to too. Hi everyone, thank you for joining us for the Opportunity Task Force. And as always, we like to start off by thanking the planning team that comes together to help us think through these ideas and to think about what topics might be most relevant to us at the East Bay Leadership Council. Today, we're talking about mobile crisis response and crisis response initiatives in general. And we're really excited that Assemblymember Rebecca Bauer-Kahan was able to join us to talk a little bit about her involvement in these initiatives. So thank you so much for being here. We do really quickly have a short presentation that Tech Exchange is going to do, which is a nonprofit here in the East Bay. We just wanted to let everyone know a little bit about them, and we thought this would be a great opportunity for them to do a quick introduction. So I am quickly going to give some privileges over to Amy so that she can give us a little bit of a background about Tech Exchange. Amy, you should be a co-host and be able to screen share now.
Great. Thank you so much, Lindy, Bob, everyone. We're so grateful to have the chance to talk with you a little bit today and tell you about Tech Exchange. I'm going to share my screen now, and hopefully you will have a chance to learn a bit about Tech Exchange here. So again, thank you so much. We appreciate having the time to talk with you. Tech Exchange has been around for about 25 years, and we've been addressing an issue that has been around for quite some time. Obviously, the digital divide has been around since the beginning of the digital age, but in 2020, it emerged as an even more important issue. Obviously, there's the issue of at-home learning. That was what was the issue that really drew the public's attention most, but there are a lot of other things that people do all the time using their computers, and we need to make sure that folks can connect with society in all of those ways. Unfortunately, a lot of people don't have that connection that a lot of us take for granted. They lack computer devices, they lack internet connection, and they sometimes lack the digital literacy skills to make use of those tools. And that problem is a problem not only nationwide, but in the Silicon Valley and the Bay Area as well. You wouldn't think that we would have a problem like this at the heart of where the digital age began, but we do, and the problem is stark. So Tech Exchange is here to help with that. The way that we do that is through a mixture of addressing the device portion of the problem by soliciting computer donations, used computers from corporations and businesses in the area, refurbishing them, and then distributing them through our programs and partnerships to the folks who need them. Along the way, we also have a workforce development program that helps to train young people in our neighborhoods to have those high-tech careers and give back in some other ways as well. So we are very proud of the work that we do. We are proud that we've been here for 25 years doing it. And we're also proud that we've actually won some awards, including recently the Multiplying Good and KPIX Jefferson Award, which was awarded to our leader, Seth Hubbard. So I'm going to let KPIX talk for us for a little bit and share this video with you here.
One etiquette, they were ready. Technology Exchange refurbishes used computers to give away at free to low cost to underserved folks who can't afford desktops, laptops, or tablets. Executive Director Seth Hubbard grew the nonprofit in 6 years from serving fewer than 1,000 Oakland families to 34,000 families in the Bay Area last year.
Living in the Bay Area, the heart of technology for the world, like this should not be an issue that our underserved community members struggle with.
The switch to online learning exposed the depth of the digital divide.
When the pandemic started, less than 25% of families in Oakland had all the tools, the number of Chromebooks, the number of students, the internet access that they needed.
Today, 98% have what they need.
I'm thrilled, excited, but also wanting to not lose the potential of sustaining this.
Seth and his team closed the huge gap through Oakland Undivided, a partnership with the city, Oakland Education Fund, and Oakland Promise. With $13 million in funding, the program connected folks to the internet and distributed more than 28,000 computers, thousands of them refurbished by Oakland Technology Exchange.
Oh, okay.
Alicia Huerta brought home a free computer years ago. She and her son Juan recently got a free tablet.
Tablets and computers can get very, very expensive, especially when you have 3 kids at home that are doing online learning.
It's used for K to 12.
Like if we're sharing one, it's going to be hard for us to share. And if we have multiple, it's going to be easier.
Thank you.
More happy customers. So it's a good thing.
The 26-year-old nonprofit also offers free tech support. It's answered more than 10,000 requests for help last year by text, email, phone, or at its store on International Boulevard. Technician Marquise Whitley, a former intern, says Seth's leadership makes all the difference.
He is one of the reasons why I do come to work every day. He makes me feel like I'm part of the team.
So for helping close the digital divide in Oakland through Oakland Technology Exchange, this week's Jefferson Award in the Bay Area goes to Seth Hubbard. Corporate donations dropped 60% during the pandemic, so Seth is hoping that corporations will donate their used computers when they get new ones. Meantime, the nonprofit's getting ready to resume computer training on site at public housing locations. Alan.
We need.
One in.
So thanks for joining us with that video. We're very proud of Seth and very proud of the work that we've been able to do in the past year, certainly in our own crisis response during the pandemic and for all of the years before that, and looking forward into the future. Now that we've built our operations up some, we have an increased need for our computer equipment donations. And I believe our Director of Strategic Partnerships, Joel Pena, is here. Joel, did you want to hop in and say something about our equipment donations?
Yes, hello everybody. My name is Joel Pena, Director of Strategic Partnerships for Tech Exchange. Thank you for allowing us the opportunity to present what we do here in the local Bay Area. Yes, we do have an increased need for devices. I think we got a lot of visibility with the Oakland Undivided campaign. We're successful in connecting 35,000 students with hardware and hotspots. But we are in need of devices ongoing, and the projection for this year is 10,000 devices. And while a lot of folks have come out of shelter in place and are coming back, to work hybrid, some remote still, there still is a need for devices. So we do have a truck that goes up and down the Bay Area 5 days a week. So if you do know an organization or you're interested in finding out more information, feel free to reach out to us. Information's here, or to Amy or to myself. And again, thank you so much for the opportunity.
Thank
Thank
you,
you.
Joel, and thank you, Amy.
Yes, thank you. We've got a lot of different ways to get involved. Equipment donations, sponsorships are certainly helpful for us. We've got employee engagement opportunities and volunteering. So lots of different ways for you to learn more and get involved at Tech Exchange. Again, thank you so much, Lindy, and everyone at East Bay Leadership Council for inviting us to be here today. Thanks.
Thanks, Amy. Okay. Before we jump into our presentations today, which I'm really excited about, I did just want to ask all of our members and visitors here today, if you would take a moment to introduce yourself in the chat, that would be great. Unfortunately, we just don't have time in this program to go through and say hello to all of you, but it's wonderful to see your faces, and I'm sure we'd all like to get to know you in the chat. So if you have a second to put that in the chat, that would be great. Now I'm going to turn it over to Kristen, who's going to do an introduction for us.
Well, thanks, Lindy. We are so fortunate today to have Assemblymember Rebecca Bauer-Kahan here. She was elected to represent the 16th Assembly District. I'm a constituent in 2018, and she is an accomplished attorney, environmental advocate, community volunteer, law professor, and mom. She's a proud product of Bay Area Public Schools and is a graduate of the University of Pennsylvania and the Georgetown University Law Center. She's going to give us some remarks, and she's certainly been a warrior for a lot of key issues, particularly around behavioral health, which is why we're so glad that she's here today. So Assemblymember Bauer-Kahan, please take it away. Thank you so much for being here. And please take a minute to make sure you let us know the strong track record you had with the governor signing the bills that got passed that you authored. So thanks so much for being here today, and look forward to your presentation.
Thank you so much, Kristen and Lindy, for having me. It's fun to be here, and I apologize in advance. I had a prior commitment that I have to run to at about 2 o'clock, so I don't get to stay for Dr. Chavano's presentation, but she's doing such incredible work here in Contra Costa County. I'm so grateful that I live in Contra Costa, so I'm grateful that she's leading the charge for me and my family and a lot of my constituents. So yeah, it's fun to be here with all of you. I think we're at a turning point in mental health advocacy that's a really exciting one. I think when I first got to the Capitol, not many people were even talking about it. And there is a mental health caucus that Senator Bell was the leader of until his departure, which now Senator Wiener has taken over with Senator Eggman. And we do work to bring this issue to the forefront, but there really has not been the focus on it that is required in the legislature. It is an area that it really needs so much more of our attention as a state in order to provide the resources to our local entities, many of whom are trying so hard to provide incredible services to communities, but just need more support from us to do it. And so with that, we decided to jump into the space and get to work on mental health. And we didn't start small, we started big. So this year we introduced AB 988, which is a really important piece of legislation that comes from a federal enabling legislation that formed the 988 phone number. So in July, you will be able to call 988 and get the suicide prevention hotline. So the idea is currently it's a 10-digit number, hard to remember. If you're in a moment of crisis, we want to make it easier for you to find that. The federal government want to make it easier for you to find those resources and get the help you needed. In the process of creating that legislation, they enabled the states to go further, right? So it's going to ring, you're going to get the suicide prevention hotline no matter what the states do, but they enabled us to use the phone number to do more. And that's what I'm trying to do with AB 988, which is a couple of things. So we want to make sure that when you are in mental health crisis, you have access at that moment to mental health services. And there are incredible counties like Contra Costa and Los Angeles that are working to do this. We want to make sure that we're creating easy inroads, right? So 988 we think is a really easy way to access that. There's going to be a rollout of that by the federal government, and the data shows that there will be about 30% more calls coming into those centers as a result of that rollout, people just knowing it's available to them in crisis. So we did this year get $20 million to build up those call centers to make sure that we were able to answer those calls. The last thing we wanted was unstaffed call centers and a rise in calls and people sitting on hold in mental health crisis. So we started with a $20 million investment this year, but the goal with this legislation, which will continue moving in the Senate in January, is to create a really robust statewide system that really looks a lot like what is happening here in Contra Costa, right? So a system where you will be able to call these 988 telephone numbers, you will get someone who's trained in mental health crisis, right? These suicide prevention hotline staffers are really well trained to handle someone in crisis. And then if you need someone on the spot there in person physically, we are going to fund you getting a mobile crisis response team. That's a really complicated thing to do in a state like California that is as large and diverse as we are. Our counties look very different, right? So we live in fairly urban, dense counties, but think about Northern California, where we have large counties where, traveling between homes is not quite as simple as when you're in Concord or Walnut Creek. So how do we make this work in every county in California is the problem that we are trying to solve right now. And really our goal is twofold. One is to fund it, to make sure that our local entities have the money and resources they need to provide these services that we think are so critical, and also ensure that we're changing the dynamic. So one thing we're doing, we plan to do, which I'm really excited about, is make 911 and 988 interoperable. So if you don't know about 988 and you call 911, but you're in mental health crisis, the 911 operator will be able to transfer you. So these numbers will just work seamlessly. And that way we're serving all people in mental health crisis with mental health services, no matter where they call. And we have the ability to do that through OES. And then also that we are ensuring that when you are in mental health crisis and you are not a threat to others, and you just need mental health services, that's what you get. You don't get law enforcement. Today, when you call and you're in crisis, you get police officers in most of California show up at your house. And these individuals are not appropriate for the public safety system. They are appropriate for a healthcare system. And so we're really trying to shift in all of California this out of the public safety system and into the healthcare system. And in so doing, right now, the largest mental health provider, and that's a generous name, in the nation is the LA County jails. When I learned that fact, I was shocked. I was upset. How can we even call the jails a mental health provider? They're not. They're places to incarcerate criminals, right? And instead we're incarcerating our people in mental health crisis, and we need to be providing them with healthcare services. So that's part of what we are trying to do. So we are really trying to set up a system where we're taking folks out of that criminal justice system, putting them in the healthcare system, and giving the resources to our local counties to provide the system of care that goes under, which I know Dr. Chavano will talk all about what's happening here in Contra Costa, which is, what we really envision is that our local counties will set up systems of care that we are providing funding for and the access into. And again, that will look different in different counties because the needs of the individuals there are different and the counties look different. This is obviously critically important work because people deserve this. I'll just start with that. It's an issue of dignity and care. But the data is pretty phenomenal out of the pilot programs that are happening around the country on this. And I think it's important to note two things about those, the data we're seeing out of these programs. One is that we're seeing people diverted from both emergency departments, but also jails. So Dallas, Texas, and we don't always think Dallas is leading the way when it comes to reform, but here we are. They did this and they saw just in 9 months, 900 people diverted from emergency rooms and 500 people diverted from jails, right? So we're getting people out of our emergency departments and out of our jails and into care that makes more sense. It's also fiscally really incredible how much these programs are saving our local communities that are doing this. So in Eugene, Oregon, we've seen an $8.5 million savings in the public safety system from this program, which is pretty phenomenal. They were able to take 17% of police calls out of police and put it into this Kahoot system. And in another system, in Phoenix, we saw inpatient spending go down by $260 million. And they prevented $37 million in cost to the emergency department. So we're saving money, we're providing better, more responsible care, and hopefully saving lives. 25% of officer-involved shootings are people in mental health crisis. So if we can take that out of law enforcement's reign of responsibility and put it into the people who actually know how to communicate with people in crisis, we can actually make a huge difference in what is happening with our officer-involved shootings on our streets. And we've seen that right here in the district I represent, right? We've seen several people in mental health crisis who have died at the hands of law enforcement. The bill is actually named in memory of Miles Hall, who was one of those individuals and really inspired this desire to, as a state, step up and do more to provide these resources to ensure that a family like Miles has someone besides law enforcement to call when in mental health crisis, although obviously he is one of many people who have suffered from mental health crisis and died in the process. So that's a little bit about what we're working on. As I mentioned, this is one piece of the puzzle. I was just on with a reporter the other day who said, well, what about all the other parts of the continuum of care? They're all so important. And I'm not by any means saying that I am solving all of that. This is a really important entryway point in for those suffering in acute crisis, but we have so much work to do underneath it to make sure that we're providing the resources to our counties to provide stabilization services and long-term care for individuals who are in mental health crisis, so they never get to the point where they need the type of response that Miles Hall's family got. So that's really the work we're trying to do, and we will continue to do in January. I know, this is, again, as I said, it's one of many things that is happening. Another important piece of legislation that was just signed into law was AB 118, which was Senator Kamlager's Crisis Act, which funds grants for our local nonprofits that are doing this type of work. That's a really important piece of this puzzle as well. I've talked a lot about the counties and the important infrastructure they provide, and that's really the vision we have for 988, is that it will funnel into a county system that is controlled by our behavioral health directors and providing sort of this very cohesive continuum of care. But we know that an important piece of that is the nonprofits that are providing mental health services, and will hopefully get a boost from the AB 118 grants that will be coming their way. So just that's the update I got for you today. I don't know if we have time for any questions. Lindy, I'll defer to you on that.
We do have time for about one question. Is there anyone who had a pressing question or was, wanting to ask the assembly member something specific about this? I'm not seeing any hands jumping up. I do have a quick question since, we're still kind of talking about it. I'm just curious, if someone was to call this number, it would be a completely separate call center from the 911 call center. Is that correct?
Yeah, the federal legislation dictates in this part. We've gotten some feedback on it. It's not up to us. So this is done. It has to go to certified suicide prevention hotline call centers. So so it is separate from your 911 calls. Although the vision really is that it would function similar to 911. So when you call 911, you are getting someone, you don't know if the person is who you're talking to, but on the back end, they're making sure you get a fire truck if you have a fire, or an ambulance if you need medical help, right? And the vision here is very much the same, right? That you will have this trained suicide prevention person per the federal legislation, but on the back end, the county will be the ones determining what level of services you need and deploying them, just like on 911. So for the user, it's a really seamless experience, but on the back end, we have the counties ensuring that the care is appropriate and there is warm handoff.
Great. It looks like our other speaker, Dr. Tavano, actually had a question. Go ahead.
Actually, thank you all. And it's not a question, it's a comment. Really wanted to call out and appreciate Assemblymember Bauer-Kahan, because by introducing this legislation, while we in Contra Costa was already starting to work, there were many counties that had not even thought about it. And just by way of AB 988, it just opened the dialogue. And so now all counties are participating in discussion. So you really opened a whole avenue of thought statewide with this. So very appreciated.
Thank you, Dr. Chavano. And I'll say, I see Dr. Roth is on too. So the incredible leader of this whole effort, obviously, as well. And I also see some incredible people from the Trinity Center and some of our homeless providers, which is also really critical to this work, because 1/3 of our homeless population in California, we estimate, are suffering from mental health crisis. So again, to the extent that we as a state are trying to deal with this homelessness crisis, this is such an important piece of that, because those individuals suffering have to get the care they need in order to really succeed and be permanently housed. So I see this as, criminal justice reform and homelessness response and healthcare, and it really is encompassing a lot of what I think Californians need. And again, the county and our local providers are so important to that work.
Absolutely. Thank you so much for being here and taking time. This was really informative and helpful, and I'm excited at how well it loops into our next presentation. So thank you again.
Thank you all for engaging. Good to see you all. Good
to see you. So we are going to jump into our next presentation, which, hold on one moment. Okay, there we go. Which will be a presentation with Dr. Chavano from Behavioral Health here in Contra Costa County. But as the assembly member noticed, there's a lot of members of our Contra Costa County family here. So thank you so much for being here, those of you who've joined us. I am going to have the pleasure to introduce Dr. Suzanne Chavano. She holds a license as a registered nurse, certification as a public health nurse, and a licensure as a clinical psychologist. She's been busy. She has master's and doctoral degrees in psychology, and she's worked in leadership positions in public and private behavioral health systems, and is currently the director of behavioral health in Contra Costa. Being duly trained as a nurse and a psychologist, she understands the intersection of mind and body and the importance of whole person care, and we are very fortunate to have her here in the East Bay. With that, I'm going to hand it over to you, Dr. Chavano.
Hi, thank you. Thank you so much, Lindy, for that introduction, and so nice to meet with all of you today. And I think maybe Dayanara is going to control the PowerPoint. Is that right, Linda? Yeah.
Yes, she has co-hosting, and so hopefully she's able to share her screen. Then, oh, there we go.
So thank you. And many of the comments that the Assembly member made really dovetail with all of this presentation that I'll be doing now. And it's short, wanted to allow time for a Q&A so that we can kind of fill out the conversation a little bit. But as I mentioned, Assembly Member Bauer-Kahan really opened this dialogue about community crisis response throughout the whole state. We in Contra Costa had started digging in on the work a bit before she introduced her legislation, but it all starts coming together. So again, I do want to acknowledge her because by bringing her piece of legislation forward, it became a countywide, a statewide discussion, and not just our county and a few others. I would say that most counties at this time do not have mobile crisis, so we're a little bit ahead of the game in that respect, but we have so far to go with it. So Day, you could do the next slide. So a lot that went on before we even began the planning process. We have been doing some level of mobile crisis for about the last 3 years with adults, and just saw the growing need. We really were focused on the Medi-Cal population for the most part, but again, really saw a greater need within the community. Also, we're looking at the different ways that people accessed crisis care, and really started thinking about it within this framework that there were already 3 existing branches of crisis response, one law enforcement, the other medical, EMS, and the other fire. And what was happening to some very large extent, and continues to happen so far, is that many of the calls for crisis care, for crisis intervention, particularly mobile crisis, are going into these other dispatch systems, delivery systems, particularly law enforcement, but then of course EMS, medical, and fire also participate in those responses. So on the one hand, people are calling the number 911 because it's very accessible. It's the one many people know, but are not necessarily reaching the most appropriate responder for that situation, meaning behavioral health crises. So many calls are going to law enforcement that really would be more appropriately coming directly to us so that we could provide a behavioral health intervention rather than a law enforcement intervention. And would like to add here that members of law enforcement and the many staff of police departments that we've spoken to really say the same thing, that some significant percentage of calls that they receive, and some say 15 to 20%, really have to do with behavioral health crisis and not a matter of law. So we are all working very collaboratively as we go forward with this initiative. And, you know, I would say in addition, when 911 is called and it's a police officer that's deployed to the scene, they're responding within a certain framework. We know that at times people, when you go to provide a mobile crisis intervention, they might be sad, depressed, anxious, but then there are other times when people are experiencing very acute mental health, behavioral health issues, and can at times look very frightening, aggressive, etc. And oftentimes those people are treated or approached based on their behavior rather than what's creating or causing or underlying the behavior, which leads to a fair amount of stigmatizing, and also, as the Assembly member mentioned, can also result in the person being arrested for social nuisance crimes and incarcerated. So we really want to move away from all of that. The way to do it is to develop behavioral health as the 4th arm of emergency response. So we can go to the next slide. So again, talking about the need, and we know that behavioral health issues increasingly are being recognized as a major area of need, as the Assembly member just discussed. For decades, behavioral health was on the radar, but not fully on the radar. It's been a struggle over decades building up our delivery system, in that it's been fairly underfunded, under-recognized the importance. But now that the community is better understanding all of the complicated issues that are a part of behavioral health in the community, there's increased attention. We have more opportunities to look at our delivery system, how to build it out more fully. So again, an increasing recognition that behavioral health is very important part of health. And what we know nationally is that 1 in 5 adults experience behavioral health issues. I would say that during this pandemic, that people have had an increasingly hard time. So if people entered the pandemic period with pre-existing behavioral health issues, could only become more intensified as the pandemic went on, for all of the reasons that we all know. And then in addition, people who did not necessarily have behavioral health issues that they were basically approaching resolving, have as a result of the many facets of the pandemic. So the 1 in 5 adults has been the historical one. It might be a little bit different right now, but it's very significant. And then going back to something I mentioned a moment ago, the third most common calls to EMS are around people experiencing behavioral health crises. And then when we look at the number of people who are out in the community and are placed on 5150 codes, everyone calls them 5150s. That's from Section 5150 Welfare and Institutions Code. And basically what it allows, that code allows for, is a person, a trained person, to determine if an individual meets the criteria for involuntary treatment. That's essentially what 5150 is. What we saw going into the whole data review that we underwent is that in Contra Costa, there were over 10,000 involuntary holds, 5150 holds, issued during the preceding year. And we actually looked backwards, and that has been steadily growing, but steady and not really going under that amount. So this goes a bit to what the assembly person was referencing also, is that responding to a crisis in the moment is responding to the crisis in a moment. And it's so important to look at what is available to people prior to that crisis occurring to prevent crises. Once they are experiencing a crisis, there's the in the moment response, but then how do we provide ongoing supports so that person moves out of the crisis safely and in a healthy manner? So we can go to the next slide. So a lot of attention was going on over the last couple of years. We know that the call for social justice has been heard loud and clear. We were watching the many very unfortunate incidents of law enforcement responding to people who were in acute crises and not having good outcomes. We know in our county, the name of Miles Hall is brought forward very frequently, and a very unfortunate death of Miles, who was experiencing a behavioral health crisis. But what we also knew was that in addition to Miles, there were a number of other of our community members who had the same experience. So it was not an experience of one, it was an experience of many. And how did we start approaching this so that we all were working together in a more comprehensive and appropriate way? And the starting point for that was really bringing together a very large and diverse group of people who would bring forward the many different perspectives on what a crisis is, a behavioral crisis is, and what would be the best way to respond to that crisis in the moment in the community. So you will see here the many participants that pulled together and really volunteered a great amount of time in understanding where we were in the moment with our limited mobile crisis, really looked at it very comprehensively. What were the different moving parts? What were we missing? What did we have? What could we do better? So what you see are the pictures of all those many people who really spent weeks and actually months devoted to this work and designing where we needed to go. There were people with lived experience, families with lived experience, members of law enforcement, EMS, fire, many community organizations participated, other staff from other parts of health services, many community-based organizations. So it was a very, very robust group of people who came together to really embark on an improvement event for all of this. Really started by looking at all sorts of flows in the current process, the existing process, where there could be more efficiencies, where there should be change, where there should be improvement. And then all the different pieces that quite honestly have been lacking from that mobile crisis delivery system that we've been working on for the last couple of years. So these are the many participants that really devoted a lot of time, a lot of very important perspectives, made it really very real in a lot of different ways. Health services, you'll see at the bottom, we were a convener, but we had partnerships. There were members of the Public Managers Association that we continue to meet with about every 2 to 4 weeks, depending on what's going on. So they were very actively involved and represented the city managers of all the cities in our county. Historically, if anyone has ever seen this slide before, we had basically the logos for those 6 cities. But in all of us talking about it, felt that we should recognize all 19 cities in our county that are really contributing and supporting this effort. So we can go to the next slide. So the conclusions that came out of the design team work that went on in the rapid improvement events really came with, really culminated with 3 clear goals. And that is that anyone in our community, anywhere they are located and at any given time, would be able to access timely and appropriate behavioral health crisis services. So anyone, anywhere, anytime, which then converted into A3. So Contra Costa A3, representing anyone, anywhere, anytime. I would say that this is a very large movement from what we've been doing for the last 3 years, because we've had a limited number of mobile crisis staff and teams. And what we were hearing is that there were many people that we weren't being able to reach, we were not being able to respond timely, et cetera, et cetera. So really the goal of this whole initiative is that, again, anyone in our county, regardless of being a Medi-Cal beneficiary, commercially insured, uninsured, et cetera, anyone in our community will have these services available to them. And wherever they might be in our county, and even though compared to some of the large southern counties that have very large geographic areas, we all know that for a county of about 1.2 million, we go from the Bay to the Delta, up to the Bridge and down to Alameda County. So we actually are a large geographic area, and really taking on how we would be able to respond timely to anyone wherever they might be would take a very different approach and a lot of different resources than what we have been having in place so far. So we can go to the next one. So the A3 model, so someone is in need, they need help. They can pick up the phone, they need to talk to someone. In talking with someone, they need someone to respond. And then based on what their needs are, they need a place to go. So those were the 4 basic tenets. Someone's in need, they need to reach someone, that someone needs to help them with the right response, and the person needs some place to go after the moment of the crisis. You can go to that next slide. And so this is how we start building it out. On the left-hand side, a need for help, someone to talk to, someone to respond, a place to go. how do we accomplish that? So we really stepped back, and I think this diagram lays it out pretty well. It's one picture that says many, many words here. So there's a crisis call, and what we know from the calls that we have already been receiving for the last 3 years, they come from many different places. Oftentimes family members, oftentimes the individual, him or herself, law enforcement. We get many calls that come into our behavioral health access line that are actually crisis calls. They need to move over. And then also, as we all know, the Contra Costa Crisis Center is our nationally certified suicide prevention line, also our 211 line. And they receive many calls also that really needed a place to go for a response other than a warm phone line call. So many calls coming in, and where do they go? How do we respond to them? So the calls come in, and we know that in the future, we would like many of the calls to come directly into the Miles Hall Crisis Hub, which is really the beginning of that hub is the call center. But we also know that calls will continue to go into law enforcement, and that there will be this interplay between the Crisis Hub and 911. And as Assemblymember Bauer-Kahan was just talking about, the 988 line will be another one of those points of contact with many people, knowing that 988 line, it's a nice, simple 3-digit number. We want everyone to know it equally as well as they know 911. And as the Assembly member was just talking, down the line, having 988 and 911 converge in a bit of a different way will be an important step. And those calls will be coming into us to the call center as well. So we know that even when you have established lines, many people will figure out other ways to call in. We want to be sure that everyone calling in is captured through the call center. So if we start with the left-hand side, that's the Miles Hall Community Crisis Hub, the location of the call center. Within the call center, there will be multiple functions. It will be answering the phone. It will be going through a screening process, which is really more of a triaging process to understand what the level of need that individual has at that particular moment. And then based on what the level of need is, provide the appropriate response. We know from call history from the last 3 years that a significant number of calls that come in that are crisis calls actually can be de-escalated by phone. It's people really wanting to talk to someone in the moment, might be not knowing where they could go for ongoing services, etc. So not all calls coming into a call center will result in a mobile crisis response, but many of them will be. And so then the triage really will amount to, what does this person need? What level of intervention? And our hope is to have 3 levels of teams. The level 1 team will not have licensed clinicians on them. We're really thinking of them as having more people with lived experience, community experience, probably paired with an EMT, really addressing social determinants that contribute to a crisis, whether it's homelessness, lack of food, clothing, etc. Those are crises that occur in people's lives. It's not necessarily an acute behavioral health crisis, but it is a crisis. So we want to have the right level of team to respond in those cases. Also, well person checks. It's not uncommon that law enforcement will receive a call saying, I think something might be going on for this person. Could you go and check them out? So we're thinking the level 1 teams would be able to perform that function as well. The level 2 teams would have clinicians and people with lived experience as the core members. And then what we're hoping to do is to build out the capacity to also have trained SUD counselors that are part of the level 2 teams, dependent on the major components of the crisis that the person is in at that time. The level 3 teams is really an extension of level 2 teams in that that is where co-response could happen with behavioral health providers and law enforcement as needed. And again, this is going to be an iterative process. There are going to be many times where a call comes into 911 and doesn't need to have law enforcement and will come over to the Miles Hall call center. There may be some times that we'll receive a call that actually should go to law enforcement. And we, during the rapid improvement events and the work of the design team, it was really starting to identify when is a situation of behavioral health crisis that just requires a behavioral health response, or when is that situation also calling for the need of law enforcement. And then there are other times when we know it's really law enforcement that should most appropriately respond. And under 911, you can see where fire, paramedics, so EMS and law enforcement sit. So if we go back over to the left side just for a moment, once the crisis in the moment is addressed, people need more after that. Some people will be able to get back into outpatient services if that will be sufficient. But we know that there are other situations that will need more ongoing care as it stands now. People might go to a hospital. They might go to psychiatric emergency services. What we're hoping in the future is that we'll be able to have the capacity for peer respite and also sobering center capacity. And then any number of other destinations. As it stands now, we have crisis residential programs that are a step short of inpatient psychiatry. So we'll want to continue to identify what other alternate destinations would be appropriate for people. So we can go to the next slide. And so again, the Miles Hall Community Crisis Hub, it will be staffed. The call center will be staffed. There are multiple components of the crisis hub. So I'm focusing right now on the call center. So the call center will be staffed 24 hours a day, 7 days a week by clinicians and peer providers. The calls will come in, they'll be triaged. There'll be a determination made about the appropriate level of intervention. That intervention will be provided, whether it's a warm line support or, as we know, increasingly dispatch of mobile teams. The decision will be made about what the appropriate team is to dispatch to that particular event. And then once the crisis is resolving, it's linking them to the appropriate services that they need for ongoing supports, whether it's right in that moment or a little bit further down the line. So we can go to the next slide. So the progress that we've been making so far, this has been a very robust project starting just about a year ago when the team first started coming together, refining the aims, identifying the priority areas, identifying what the rapid improvement events were, really thinking through the data, what data needs to be collected, etc. And then March and June really went into a learning collaborative mode and operated 3 different rapid improvement events, again, testing out some of our assumptions and then refining next steps. And summer and fall, which is where we are now. So we have a lab, I guess we'll call it, operating 3 days a week for limited number of hours, where the calls that would be going directly to our mobile crisis response team are being diverted into this call center so that we could start having a better understanding of what a very effective triage tool would be, what the levels of teams would be, how we would deploy those teams. Quite honestly, there's been a lot of really months of work done on telecommunications because that's where it all begins. And where we are now is really going into testing of a dispatch system. And so 2022, we're going to continue with implementation of refine, spread, and scale. We're really looking at infrastructure. Again, how do we get all the telecommunications in place, a dispatch system that's highly functional so we can know where the teams are at any given time. We'll be working on expanding the number of mobile teams. We'll continue coordinating with all of our many partners. And then we will continue to build out our continuum of crisis services. So we can go to the next one. So just wanted to give you a brief update on mobile crisis response for adults that we've had in operation for the last 3 years. And the changes we're already seeing, really starting back in last November when the design team was pulled together and people started talking about this. So we have continued to look at the data, and what we've seen is that in the last year, the number of calls coming in has more than doubled. But we are collecting a lot of data so we know what the need is in every city and in the county, so we can really put together a robust system. So right now, we know that the majority of calls, over 40% of them, are originating in either Concord, Antioch, or Richmond. In terms of who's making the calls, almost half of them are actually coming from family members. And then over 20% now are coming from law enforcement, and about 9 to 10% are coming directly from the individual. And then there are a whole other number of places where calls are coming from that constitute the remaining percentage. Excuse me. Over 2/3 of the calls that are coming in are psychiatric in nature, and that seems probably an odd thing to say, but we're really trying to make some discrimination between acute psychiatric crises, mid-level behavioral health crises, and what is a crisis and what isn't a crisis in terms of mobilizing teams. And what we would also want to note here is, I think all of our continuing tendency is to say mental health. We're really trying to change the language to behavioral health, because what we know is that people are experiencing crises related to substance use. They may or may not have a mental health condition, and we want to be sure that we're responding appropriately there as well. And then this last box, just wanted to mention again, just, it's the Hawthorne effect. If you look at something, it starts changing and hopefully improving. So since our conversation started about the whole initiative and how do we serve people better, we're seeing that law enforcement now, the calls coming from law enforcement have steadily been going up each month. So when I look at historical data, it was maybe 2% of the calls. Right now, we're up to about 10% of the calls are coming from law enforcement, where they receive a call and they're calling us and saying, we think that this is more appropriate for you to respond to, and that's what we're doing. So that's just a little update. I would say we have mobile crisis response teams for adults, and those were the ones, that was the data I was just talking about. We also have some teams that are specific for youth and are part of the Families Urgent Response System partnership with EHSD. Also looking at the data, what I would say and what I'm finding and talking with people around the state, that the majority of calls that come in for mobile crisis usually fall somewhere between 8:30 or 9 a.m. up until about 8 p.m. And then the calls from 8 p.m. to 10 p.m. go down, and then after 10 p.m. go down even more significantly. And then again, just the call volume from 3 years ago, we were averaging about 32 calls a month going directly to the mobile crisis response team. And now we're at about 300 calls a month, and that's growing. So I will stop there, and I'm not sure, Lindy, of timing. I wasn't watching the clock. I'm so sorry about that. I'm not sure how much time there is.
Well, that's incredible that you weren't watching it, because you ended right at 2:25, which makes you quite skilled at keeping us right on time. We do have time for one or two questions. We go until 2:30. So if there's anyone who had a burning question, feel free to put it in the chat or raise your hand, the little mobile raise your hand. Sorry, digital raise your hand. Otherwise, thank you so much for being here. This has been recorded, so it will be available if any of you would like to share it. We'll include that in our newsletter probably this week, if not next week. And we put it up on a YouTube channel so you can share that. But again, thank you so much for being here. I'm looking over to see if I see any questions.
Lindy, can I add one more comment? Sorry, I should have said this. Is it okay if I spend one more minute on this?
Yeah, go ahead.
Yeah. Right now, and I think Assemblymember Bauer-Kahan reminded me of this also, and your question about AB 118. What we know already is that some cities in the county are moving forward with their own local initiatives for mobile crises. The city of Antioch, the city of San Ramon, the city of Richmond. And we are already talking with them, coordinating. And then with AB 118, which actually is a piece of legislation which authorizes Employment and Human Services, so social services, to also grant funds for mobile crisis intervention. It'll be interesting. We'll see how that develops. They'll have a stakeholder process. All to say that we want to support every effort that's being made, and then at the same time hope and plan that at some point all of these initiatives and efforts will come together so that they're very integrated and whole and really working to serve the full community.
Great, that's encouraging. No, that's encouraging to know, because I've heard other cities kind of starting these conversations, and it's good to know that there's a collaboration that's occurring. There was one question in the chat. Rebecca asked, Rebecca Rosen with the Hospital Council asked, what is still needed to get the system fully up and running?
A lot. I mean, quite honestly, and people have heard me say this lately, and I feel it that way. You know, we set up our existing mobile crisis about 3 years ago. I call it a mom and pop shop, not because of the clinicians or the services, they're great, but the people now who are doing the mobile crisis are also the people who are answering the phone. So they're answering the phone, they're doing warm line support, they're doing the triaging, and then if a person needs mobile crisis, they get in a car and drive out. And that really slows everything down. It really limits our capacity. So it's really building, we need to build out this whole system, really beginning with the call center and having it be very high tech, including this very formal dispatch system. And then we need to build out all of the levels of teams that are needed. And then also the resources. The hub we're hoping is actually a physical hub. The dream of it being that would be where the call center would be sited, but also the headquarters, the centralized headquarters for the mobile crisis teams, but they would also be outstationed as well. But then also to be able to provide a whole range of crisis services, urgent services at the same physical location, so that we have all the different pieces of that mobile crisis support response system in one location.
That makes sense. So we did have one other great question from Leslie Gleason. We don't have a ton of time, but perhaps you could try to answer it quickly, and we could dive a little bit more into it offline. But she says, at Trinity Center, we're increasingly working with young adults, 19 to 29. Can you say more about whether there might be some variation based on age, developmental stage, or cognitive disabilities for young adults or older adults?
Yeah, thank you for that question, Leslie. That's something that we're looking at, because as I mentioned, we have separate mobile response teams for youth and families, separate mobile crisis response teams for adults. And we really evolved that way in recognition that youth and families connected to those youth, the nature of the crisis has different nuances to it. And as you bring up the person asking the question, Leslie, there are developmental differences that we do want to pay attention to. And there are different cognitive levels of functioning that go on as well. So down the line, how we bring the teams together into an integrated whole, that's something that we're going to be working towards. But at the same time, we will want to maintain that very specialized focus on youth. I don't know if I answered the question well, Leslie, or not.
She's nodding her head yes, so I think that's a good sign.
Yes,
and
thank you.
It's 2:31, we here at EBLC try really hard to stay quiet on our timelines. So thank you so much for being here. And thank you again to the Opportunity Task Force leadership team, Cindy and Elaine. I can see you both right now on my screen. And Bob Linscheid, thank you so much. I believe Sheila Hassel-Hughes is here as well, who's also part of our planning team. So thank you all so much for joining us, and we'll see you hopefully next month.